Today we have with us Dr. Stephen John, a programmatic, a 20-year-old veteran with vast range of experience across TB, leprosy, and HIV, leading to programs in underserved populations funded by organizations like Stop TB, Global Fund, and USA. Welcome, Dr. Stephen.
Thank you very much, Jai.
Dr. Stephen, we've heard that you work in underserved population, and the topic of this fireside is also about resource constrained settings. So can you tell us a bit more about the work that Janna Health is doing, and what do we mean by resource constraint?
Thank you very much once again for having me on this platform. First, I would like to say that the population that we target, mainly the nomadic pastoralists, are located in remote, hard-to-reach areas where you have an inadequate number of health facilities, where you have serious access issues, where you also have a limitation of human resource to deliver service. So you can see resource-wise, whether it is a human resource you're talking about, or whether it's by funding, they are on the negative side. There is no much of that. So that is what we mean by resource constraint. And all government efforts are focused mainly in the urban areas, and these places that we're working are very rural. So we are delivering service to this group of people. Yeah.
Got it. So Janna Health is not only involved in tuberculosis, but other programmatic areas also. What are the other programmatic areas that Janna Health is involved in?
We tend to practice integrated service delivery. So we do tuberculosis together with leprosy, and then also HIV service delivery. So even in our capacity building for the volunteers and healthcare workers that we work with, we make sure that we integrate these diseases so that it's gonna be something like a one-stop shop. So when you go to screen like from tent to tent for nomadic people or house to house for internally displaced person, we also ask basic questions about leprosy and then HIV. Yeah.
No, it's very interesting to know why, because these are underserved communities and these are nomadic populations.
Yeah.
But then how do you liaise with these nomadic populations, because they tend to move from places to places? Then how do you track these disease areas?
This is a question that we have been asked almost every year, because people that have experience with nomadic pastoralists have this challenge. And what we did was, first, before implementing this particular project that we're targeting nomads, which started in 2011-2012, we studied the other interventions from other projects, and we saw what they couldn't do very well. Let me give you a good example. If you try to intervene among nomadic pastoralists the same way that you're intervening in other populations, you cannot get their commitment, you cannot engage them adequately. So what we found out was that we needed somebody from within to serve as a focal person. For example, we identify a staff that is a nomadic person who has worked with the Ministry for Livestock for 35 years and have retired. So this person is nomadic, and then he is responsible for vaccinating cattle. And you know, if you know the culture of the nomadic people, if you take care of their cattle, then you are their friend. So they will open up to you. So we use this person as the focal person who leads the way for Janna Health Foundation to go to all the nomadic communities where we are working. And through him, we're able to identify community volunteers from nomadic people. Through him, we're able to know the nomadic leaders and have meetings with them, discuss with them, and consider also their own issues. That means they were able to be encouraged to talk about their local priorities, which we included in our intervention. And this made the program very successful. Today, if you go to the nomadic communities in Northeast Nigeria and you mention Janna Health Foundation, they already know. And even when we are not there, for the first time, you have volunteers whose capacities have been built, that if somebody is coughing or somebody have basic symptoms of TB, they know what to do. They take samples, they transport the samples to where diagnosis occurs.
Okay, so you are treating it more as a model wherein you're bringing in experts from the community to liaise with the community and then go forward.
Yes.
But in this comes a very interesting perspective of technology. And these are resource constrained areas, both from human angle along with technological angle.
Yeah.
There are no radiographers, no internet connection, and very tough terrains. We've seen people. So how do you define these challenges, and how has technology actually enabled access and affordability to these places?
One of our biggest challenges over the years in the implementation of TB among nomadic people is our inability to make diagnosis for clinical TB cases. The reason is because the access to radiologists, like you said, is very poor. We didn't have access to chest x-ray. In the whole of my state, which is 5 million people, we have less than 5 radiologists. And in the whole of the hospitals in this 5 million, that serves these 5 million people, there are less than 5 functional x-ray machines in the hospital. And these are people that have access issues and they cannot come to the hospital because of problem of trust and then also other issues surrounding their culture. So what we were very excited when we started this work and heard about the mean X-ray and what Qure is doing with that equipment. So we're able to secure one of them. And this equipment has opened the doors for us. It has shown us that we can take X-ray to any level. We can go anywhere because it's so portable, as you can see in the pictures that are displayed here. 2 people can take the whole thing. 4 people can operate the whole machine. In 3 minutes, you set it up and you can take 200 shots per day. So this was very good. And because we're able to do this, we're able to find a lot more numbers of clinically diagnosed TB cases. So now, if you look at the profile of our TB cases diagnosed, you will see a proportion of bacteriologically negative on the increase. The machine is helping us to pick presumptive TB cases, and then we now go ahead and then take samples, subject them to gene expert and make diagnosis and link them to treatment. So this has helped a lot.
Oh, that's great. So Qure.ai software like QXR, how is the result of QXR, let's say QXR calls something as TB presumptive, how is that followed up in the live real world setting? And how do you define that threshold wherein a radiographer or a program manager has to take that decision?
When we started this work with the mean X-ray equipment with the Qure software, we started with a threshold of 0.5. So, and then after having a good number of X-rays, as doctors, we get curious. We want to study the images and see. We realize that for people that are from 0.3 to 0.5 group, there are a good number that had lesions in their lung fields. And we thought they are worth investigating. We need to see what's happening there. And then when we took samples, we realized that there are some TB cases that are having that threshold of less than 0.5. So we now reduce the cutoff point to 0.3. This was not based on any calibration. This was just based on programmatic thinking because of the result that we were getting at that point. And immediately we did that reduction. We know definitely the numbers of samples transported for gene expert, of course, increased, because we're going to be testing much more people, but so do the TB cases also increase, which was very good. And then when I came to this conference, I realized that people that run researches to calibrate and then come up with the cutoff point are now suggesting a cutoff point of 0.34, which is very close to what we thought. So this is how we're able to define that particular cutoff point, and we have continued to use 0.3 as the minimum cutoff point, and then screen whoever is having any score between 0.3 and 1 for TB.
That's amazing, because the calibration that you've done along with what you've heard around in the conference across health experts is very close to what you recognize. And this actually brings me to a point where you've seen some success story, let's say some patient story, where you've seen that there was no hope or there was no detection, but because of the use of technology or AI or X-ray, something was detected, and it served a community at large, because TB is a communicable disease.
Yes.
So can you share some examples?
Yeah. One thing that interests us so much that we are perplexed by was what we found in these communities. Remember, these are communities that had very poor access to health services, and these are communities that virtually were not doing anything about TB. And if you also remember through our work, we have published some of them, you will see that the nomadic pastoralists are at high rates of TB because they consume unpasteurized milk, they are living in poorly ventilated places, and of course they keep infecting themselves over and over. And most importantly, bovine TB is very high. So with this in the background, you will see that definitely we had to clear a backlog of cases that have given up on life. We have made cases that are bedridden. I remember in 2 of the local governments where we were working, there was this one was an old woman, the other was an old man that were bedridden to their rooms. They couldn't move. But because of this mean X-ray in their community, they were able to be brought and they were screened. They were found to have a score of almost 0.8, 0.9. I remember samples were taken and they were confirmed to be bacteriologically positive TB. Today they are well. I remember there was one community where somebody was brought, but this was somebody who had spinal TB. Now, we were screening for pulmonary TB, and the guy, they said that he fell on his farm and he couldn't stand up. So they thought that it was a black magic or something happened. But because I knew from my training that definitely there could be spinal TB, I was able to come and subject him to this X-ray because we were trained by the mean X-ray people how to take also X-ray in that area. And we saw that there was something wrong with his spine. Later, it was diagnosed by some radiologists that this is spinal TB. On medication, after 1 month, he started working. So they thought it was magic. So you see how the equipment gave hope to people in the community who had no access to TB services.
Wow, that is so heartwarming to hear.
Yeah.
And congratulations on the amazing work that you're doing. What is the way forward for Janna Health?
At Janna Foundation, we are very lucky to have this capacity. We have people, program managers like Dr. Suraj Abdul Karim. I've been working with him, and then there are other team members that bring a lot. Now, in Nigeria, we have almost 10 million nomadic people. Where we are covering now, we have like 1.5 million nomadic people, estimates. So we have received calls from the national program to identify more states to expand services to start covering more states where there are nomadic people, because there is any organization that we know of that is handling TB among nomadic people. So we're the only ones. So we've been discussing, and then we're looking at how we can expand services to cover all the nomadic people. And also we're doing operational research to also define and see what kind of TB people are suffering from. Is it zoonotic TB, or is it the normal, the human TB that we know? So this is also very important, has implications for the future, especially for treatment regimen. So these are the things we're doing. But one thing is clear, that artificial intelligence, this work that we're doing, has come to stay. It is making things easier. It is making us diagnose TB faster. And if we want to end TB, there is no way we'll do that without this equipment. For me, I know it's good to invest on a lot of diagnostics here. We need new diagnostics, but this is one of the best that has come. If I look at the numbers of cases now, in my state, before we started this, they were detecting an average of 1,900 TB cases per quarter. Now they are detecting 1,400 per quarter. The other state, Taraba state, where we are working, they were detecting 700 cases per quarter. With our work now, they are detecting 1,400 also per quarter. So things are working. We are finding TB cases. The case detection or notification is improving. And I think the best way to go is to continue to work with equipments like the mean X-ray, with Qure.ai software, and see how far we can go in ending TB.
Well, that's great, and you've almost doubled the number of screening in both the states
Yes.
that you've done.
Yes.
And that is great to hear. More power to you. And I would like to thank you very much for your time.
You're welcome.
And really hoping forward that you take this across communities and impact as many people as possible. But many, many congratulations to you for the wonderful work here.
Thank you very much, Jai. Thank you.